Yes, as Elizabeth uploads the slides, you can still proceed with the talk.
Yes, well, first of all, we can't go by us knowing what the thromboembolic events are, because before we understand what enoxaparin is and what it does in the thromboembolic events, it is crucial for us to know what the thromboembolic events are. So normally, we shall begin by us knowing what a thrombosis is, because and as Liz will come on with the slides, the screen. Yes, thank you, Liz. From the starting, a thrombosis is the process of formation of a fibrin blood clot. Thrombosis is the process of proteins contribute to this clot. And now, clotting is good because it has its own advantages, but it becomes pathologic where it is not needed at that particular place and at that particular moment. So an embolus. So we go to an embolus, which is a small part of a clot that breaks and is carried out and is carried by the blood flow to another part of the vascular system. Normally, once a clot forms, it becomes more. When a clot forms and that part of the clot that we are calling an embolus is carried away to another part of the blood flow, then it's a clot that is in a wrong position at a wrong time. So in that way, it becomes pathologic, it becomes dangerous, and it becomes worrying. So this damaged embolus becomes trapped in the blood vessel, causing occlusion. It occludes and leads to ischemia or infarction of the surrounding tissue where it has gone and stayed. So yes, that's damage caused when the embolus becomes trapped in a small vessel, causing occlusion. It blocks. It partially or fully, sometimes partially or sometimes fully, or blocks the passage of the blood into that blood vessel and through that blood vessel, and thus causing ischemia, infarction to the surrounding tissues. So a normal clot formation maintains the integrity of the vasculature in a response to injury, but pathologic clotting can occur in so many clinical settings. So as I say that clot formation is good in its own way when it is in the right place and the right time. However, it becomes pathologic when it happens in the wrong place and at a wrong timing. So abnormal thrombotic events, which is our topic today, includes the venous thromboembolism and its primary complication, the pulmonary embolism, as well as stroke and other systematic manifestations of embolization of clots that form within the heart. So in the next slide, we can see how we can see the internal and how thrombosis is caused internally and externally through externally through hemostasis. Then when a vessel is disrupted, platelets adhere, they aggregate, and lastly, thrombin generation and fibrin are formed. Then internally, when there is a thrombosis or an endothelial injury, then the platelets do their work, and finally, there's thrombin generation and fibrin formation at this point, which is okay. So in the next slide, the next slide introduces us to pathologic thrombi. And we are saying that pathologic thrombi are sometimes classified according to the location and composition. We have the arterial thrombi and the venous thrombi. The arterial thrombi are mainly composed of platelets, although they also contain fibrin, the occasional leukocytes. Then still the arterial thrombi generally occur in areas of rapid blood flow, for example, the arteries, and are typically initiated by spontaneous or mechanical rupture of arteriosclerotic plaques followed by aggregation of plates. So arterial thrombi mainly occur in areas where there is rapid flow, and they contain fibrin. The venous thrombi are in the venous circulation and are composed entirely of fibrin and erythrocytes. So venous thrombi have a small platelet head and generally form in response to either venous stasis or vascular injury after surgery or trauma. The areas of stasis prevent the illusion of activated coagulation factors by normal blood flow. So we have the arterial thrombi and the venous thrombi. And it's in the venous thrombi that we have the fibrin and the erythrocytes normally occurring after injury, vascular injury, or after surgery or trauma. Then the next diagram it gives us a clear picture of what we have been talking of. The first, the one you saw on your left, shows the normal hemostasis, injury transferring and platelets are formed to. Then the middle one is the arterial thrombi. We said in the arterial thrombi, they mainly occur in areas where there are rapid flow of blood, and usually after mechanical rupture of arteriosclerotic plaques. So as you can see, there is an arteriosclerotic plaque, but again, the platelets have come in and they are occluding partially the blood vessel. So that's arterial thrombi. Then the other side, we have the venous thrombi. Remember, we said in that the venous thrombi is mainly contained of fibrin. As you can look at the fibrin and the red blood cells. Fibrin and the red blood cells mostly occurring due to venous stasis or vascular injury after surgery or trauma. So the first one shows us the normal way. The middle one is showing us the arterial thrombosis, and the third one is showing us the venous thrombosis. So I think you've seen how it is. Next on the slide. Yes. So now we are at the thrombo-embolic events. These include the venous thromboembolism from the venous thrombi, as we have seen, the deep vein thrombosis, and its immediate complication, the pulmonary embolism. Then we have the acute coronary syndrome, the STEMI, and the SOT. Next slide. So we begin with the VTE, one of the most common cardiovascular disorders, the venous thromboembolism. resulting from the venous thrombi, which we said is primarily in the venous circulation and composed almost entirely of fibrin. Do stay with us inside store. So venous thromboembolism is manifested as deep vein thrombosis and pulmonary embolism resulting from thrombus formation in the venous circulation, just as I've previously said. So deep vein thrombosis and its immediate complication. So the next diagram shows us the deep vein, how deep vein thrombosis comes in. There is in the first on our left is showing us how it looks out, what are symptoms, and as one of the symptoms. Then as you come here, you can see the first diagram is showing the normal flow. Then in the middle, it comes when you will see there is venous stasis, blood has to there has been clot formation in before just the valves. So blood is trying to go up, but a clot has formed that way. Then in the third, we are seeing one of the embolus, part of what had clotted, part of what had formed here, escaping, going up to the pulmonary circulation. So just as I said, sometimes a clot becomes, actually most times, a clot becomes dangerous when it's moved to another place where it's not meant to be. For example, this is typically going through it's going through the pulmonary circulation, and what may occur is what we are going to see in the next slide. Next slide, please. Yes. So we have seen deep vein thrombosis, and now we are at pulmonary embolism. In the down diagram, we are seeing clot has been formed, and one of the embolus is escaping to the upper, going upwards, and through until the pulmonary circulation, where it's most likely to cause occlusion and cause a lot of problems up there. So it is deep vein thrombosis. If not managed well at an early stage, not monitored very quickly, then pulmonary embolism comes in. So the venous thrombi, as we have said, is mainly deep vein thrombosis, and its main complication, the pulmonary embolism. Next slide, please. The next slide shows us what may occur after that embolus has moved right from down, then to the lungs, causing pulmonary embolism, then causing increasing pulmonary vascular pressure, right to right ventricular pressure, then later on to heart failure, then later on decreasing blood pressure and causing more weird complications, as we all know. Next, please. So I think we can, from that, yes?
Yeah, sometimes you are breaking, but we can continue.
We can continue? Yeah, so The next slide puts us to the risk factors of venous thromboembolism. One of the risk factors, family of blood clot increases clotting risk for any reason. Most times when patients are on ward and they are non-ambulant for a long time, patient is lying, for example, mostly in the ICU and orthopedic wards where patients are not usually put in motion, then they are at risk of getting venous thromboembolism. Then decreased blood flow, often caused by inactivity, confinement to bed, limited movement, prolonged travel, paralysis, or stroke. Then injury to the vein, often caused by fracture, surgery, or severe muscle injury. Then increased estrogen, often caused by birth control pills, hormone replacement therapy, and pregnancy. Then chronic medical conditions such as cancer, lung disease, kidney disease, inflammatory bowel disease, or obesity. Then age, anyone can get a clot, venous thromboembolism. However, we cannot always rush to do, then just continue with the risk factors before. Flying, surgery, the same things that we have heard from the previous slide, or pregnancy, being overweight, obesity. Then this is a general picture still. Yeah. Then right from the vein, right to arterial coronary syndrome. We go to arterial coronary syndrome. With this, just as we said, this most happen is in the arterial circulation, mainly due to arteriosclerosis, due to rupture of an arteriosclerotic plaque. Acute coronary syndrome, just a spectrum of conditions compatible with myocardial ischemia or infarction due to an abrupt reduction in coronary blood flow. Leads on arterial coronary syndrome. The next slide. Arterial coronary syndrome, a spectrum of conditions compatible with acute myocardial ischemia or infarction due to an abrupt reduction in coronary blood flow. Next slide. The diagram is just showing us, the slide is showing us the first diagram. We can see coronary artery, how blood is flowing normally. The second down is showing us but the artery has been partially blocked by the atherosclerosis. Then in the third one is showing us a clot being formed, maybe after rupture of an atherosclerotic plaque. So this most times usually either partially or fully occludes the arteries, prevents blood from flowing in that direction. So that's now. Next slide. So next slide shows us the arteriocoronary syndrome pathophysiology and characteristics. You see right from the left, a stable plaque. Then as we go with the arrow to the right, there's limited flow, platelet with the limited flow, partial occlusion because of the arteriosclerotic plaque that we have seen. Then as we go right to the right, there is total occlusion, thus blocking fully blood from flowing to the other direction. So the downer wordings just show us where priority as medics should be. In the left, we control angina symptoms, primary prevention, because it hasn't become so much worrying. Then when we go to the right, unstable angina, where we see the word rupture, the arteriosclerotic has ruptured, and thus the ruptured and the platelets have started forming the clot. Then there is our priority is at preventing total occlusion, control CP and other symptoms. Then as we go further, still the priority remains at preventing total occlusion, limiting infarct size, controlling CP, among others. Then as we go further to the right, our priority again changes to now restoring because further to the right now the artery has been fully occluded. So our priority changes to restoring patency of the infected artery and preventing complications such as arrhythmias or the final complication, which is death. Next slide. So here we are going to, after we've discovered the antithrombic events, the thrombo-embolic events, the deep vein thrombosis and its immediate complication, the pulmonary embolism. Then we have gone to the arteriocoronary syndrome. So now we are going down to knowing what really brought us today. So this is the normal stuff, thrombogenesis, when there is vascular injury, then going down platelet adherence and activation, then thrombin generation and fibrin formation, and lastly plasma generation and fibrinogen. This is the normal way. So let's go to the next slide. Yes, so we have seen how deep vein thrombosis comes in, pulmonary embolism has come in, that's the venous thrombi, then the arterial thrombi, how blood is occluded by the rupture of the arteriosclerotic plaque, and the platelet and the clot formation, sometimes partially occluding the artery or fully occluding the artery. So now what is our next step as medics in preventing this, and managing this? So there are many drugs used in coagulation, in managing coagulation disorders, the warfarin, the anticoagulants, platelets, fibrinolytics, then the direct fibrin inhibitors, Fundarinox. But our major concern today, since it is Enoxaparin, then we are down at heparins. And in heparins, where we shall, in the next slide, you shall know what UFH is, the unfractured heparin, and the low molecular weight heparins. So next slide, please. So heparin is a rapid-acting anticoagulant that is administered parenterally. Standard heparin. This is standard heparin. Unfractioned heparin. Just in case you see FH in the following slides, is hydrogenous of glycosaminoglycans of varying molecular weights obtained from bovine lung or poking intestinal mucosa, we go ahead to how heparin works. Heparin is rapid anticoagulant. Yes, the action of heparin is facilitated by its binding to the naturally circulating anticoagulant and thrombin, a serine protease, also referred to as heparin cofactor. Binding of heparin to thrombin accelerates the anticoagulant effect of the thrombin. The heparin and thrombin complex attaches to and irreversibly activates factor 2A thrombin and factor 10A, as well as activated factors 9, 11, 13. However, our main concern today will always, let's mark factor 10A most. So let's continue. Approximately 1/3 of the molecules present in the unfractured heparin bind to the thrombin and provide anticoagulation properties of heparin. So in short, it's the unfractured heparin binding to the anthrombin, providing the anticoagulant properties of heparin. We continue, Liz. Yeah, so this is a diagram just explaining what we have had from the previous presentation, from the previous slide. We are seeing unfractured heparin now binding with the anthrombin, activating factor 10A, thus activating factor 10A, thus, and we are seeing the other side, the unfractured heparin accelerating interaction of anthrombin with both thrombin and factor 10A. So it's just an explanation of what we have had in the next slide, the mode of action of heparin. So next slide, please. So here the remaining, because in with unfractured heparins, it is just 1/3 of the heparin that binds with the thrombin. The 2/3 of the heparin molecules bind, the remaining 2/3 of the heparin molecules bind to plasma proteins and to the endothelial cells. In addition to its anticoagulant effects, heparin inhibits platelet function and increases vascular permeability. These propagic effects of heparin is binding to the anthrombin, and the 2/3 are binding to the plasma proteins and to the endothelial cells. So heparin may be administered intravenously by continuous infusion, although its bioavailability is significantly reduced by subcutaneous administration. Intramuscular administration of heparin, as well as intramuscular administration of other drugs who are anticoagulated, should be avoided because of the potential for hematoma formation. So it's mainly IV and mostly subcutaneous. Next slide, please. So with the unfractured heparin, after discussing the unfractured heparin, knowing how there are 1/3 binds and where the 2/3 go, the good news is that using chemical enzymatic depolymerization techniques, unfractured weight heparin can be separated into fragments based on molecular weight. So in that, we can get the low molecular weight heparins from the unfractured heparins. So several molecular weight heparin molecules have been isolated and commercially marketed as anticoagulants. So several are now being marketed as low molecular heparins rather than the unfractured heparins. We shall know why in the next slides. So unlike the unfractured heparin, with the low molecular weight heparins, there's no the 2/3 is not there. It's just this small low molecular heparin that is binding with the antithrom. The good thing with it is that the heparin, so I think we can now get a difference between the mode of the unfractured heparin and that of the low molecular weight heparins. So let's continue, Liz. So now the next slide is showing us the unfractured heparin, the differentiating the unfractured heparin and the low molecular weight heparins, right? Ranging from molecular weight range, as you can see, the average molecular weight, the anti-factor 10A. Let's always begin with that factor 10A and the anti-2 activity. The ratio is 1 in the unfractured heparin is 1:1. Then low molecular weight heparin is 2:1 and 4:1. Then and other differences, as you can see. Let's move to the next slide. Now the question is coming, the big question. Then why are low molecular weight heparins recommended more than the unfractured heparins? In another sense, we are now discussing the low molecular weight heparins versus the unfractured heparins. One, with using low molecular weight heparins, there is little or no monitoring the majority of the patients when given on a weight adjusted basis. The low molecular weight heparin anticoagulant response is predictable and reproducible. Then two, the bioavailability of the low molecular weight heparin versus the unfractured heparin. We can see in the low molecular heparin, the bioavailability is 90% as compared to 30% of the unfractured heparin. Then another good issue is that this can be given subcutaneous versus IV, looking at the ease. And this brings us to another point of outpatient versus inpatient. With subcutaneous, you can easily teach a patient how to give an injection, how to administer it, unlike with IV that needs close monitoring of a health professional. Then there is low incidence of thrombocytopenia. In this, I'm sorry, I never first put it in its full form, but thrombocytopenia, the low, because in the mechanism of action of the unfractured heparins, we discovered that the 2/3 played another role in again limit and again inhibit formation of platelets, and yet we still need the platelets in the body. So when using unfractured heparin, there are higher chances of us running low of platelets. So yet in using low molecular weight heparins, there are lower cases of low platelets, which is there are lower cases of us losing or having low levels of platelets. So that's it. In low molecular weight heparins, we have there are lower instances of thrombocytopenia, which is decreased levels of platelets in the body. Next slide, please. The next slide is also the same question, big question. Why low molecular weight heparin and not unfractured heparins? And more is more predictable anticoagulant response, needing little or no laboratory monitoring. So you are aware of, you can predict the results in the using low molecular weight heparins. Then unfractured heparin is a mixture of large and small heparins. heparin fractions. Yet in this case, we have seen the low molecular weight heparin is doing much. We don't need those large heparin fractions that will later cause thrombocytopenia while using the unfractionated heparin. So we are seeing that the low molecular weight heparins are doing great than the unfractured heparins. Next slide. Yes. Now, unfractured heparin metabolism removes larger biologically inactive fractions quickly, then leaves behind smaller active fractions removed more slowly. Then we also look at the size. The low molecular weight heparins they definitely have a small size than the unfractured heparin. Then the next slide shows us one strong point, which is the half-life. The next point moves us to the low molecular weight, the half-life of the unfractured heparins, which is 0.5 to 1 hour. And we also look at that's the half-life. So we are seeing the difference between the low molecular weight heparin and the unfractured heparin. So there's also renal versus hepatic clearance. The low molecular weight heparin are excreted from the body through the renal, and then the unfractured heparin through the hepatic process. So we have moved down, we are moved far from the deep vein thrombosis, how it comes. We have known the anticoagulants, heparin being one of them. We have broken down heparin into two, the unfractured heparin and the low molecular weight heparins, and we have now discovered that the low molecular weight heparins are more recommended than the unfractured heparin because of the reasons we have seen, or the half-life, the ease of monitoring. You don't need to monitor so much while using low molecular weight heparins. We have seen the way of excretion, renal versus hepatic. We have seen so many. We have seen outpatient versus inpatient. We have seen subcutaneous versus the IV, which needs close monitoring. Next slide, please. So the pharmacokinetics of unfractured are influenced by pharmacokinetics of heparin are influenced by its bindings to plasma protein, endothelial cell surfaces, macrophages, and other acute phase reactants. Next slide. So there is less inhibition of platelet function. Partially, we are still on the why low molecular weight heparin and versing the unfractured heparin. So less inhibition of platelet function, potentially less bleeding risk, but not shown in clinical use. Next slide. Then there is lower, this we have discussed it earlier, there's low incidence of thrombocytopenia, low blood count, while using low molecular weight heparins versus the high molecular heparin. Then more practice for outpatient use, the low molecular weight heparins, because they are mostly administered through the subcutaneous versus the IV, because the IV, the patient has to be in ward, the patient to be on ward for long, plus its disadvantages. But here, the patient can easily go home. There's no need of that close monitoring as it is in the unfractured heparin. So next point, next slide. Antifactor 10A is something that we have to look at most. Then unnecessarily in majority of patients, well monitoring the molecular weight heparins, it's sometimes unnecessary in majority of the patients. Then samples should be drawn 4 hours after dosing. If at all you're trying to monitor the low molecular weight heparin, you have to draw samples 4 hours after dosing. Then may be useful in specific instances and patient low molecular weight heparin monitoring may be useful in specific instances and patients that need monitoring are the pregnant, the pediatric, the renal insufficiency, prolonged physical bleeding, obese patients without a drug. So in these patients, we have to monitor, to keep monitoring the anti-factor TNA in their blood. So next slide. So the therapeutic ranges of heparin as follows. The raw molecular heparin is between 0.5 to 1.2 international units per milliliter. Then unfractionated heparin 0.3 to 0.7 international units. Then the prophylactic ranges of heparin as follows. The raw molecular heparin between 0.2 to 0.5 international units. Then the unfractionated heparin is 0.1 to 0.4. We guidelines. So this brings us to enoxaparin. We have seen what the low molecular weight heparins are, and so what are the examples of low molecular weight heparins? One of them is enoxaparin. Our topic today, enoxaparin is a low molecular weight heparin with antithrombotic properties. The FDA approval was in December 1998. That's around 20, if I'm not mistaken, over 25 years back. Well, it has been approved. Enoxaparin acts primarily on the coagulation factor 10A and also, but to a lesser degree, on thrombin factor 2A. So enoxaparin indication is in prophylaxis or treatment of deep vein thrombosis, as we have seen how it comes in the pre-surgical and post-surgical, inpatient treatment, outpatient treatment, and then therapy in the arterial coronary syndrome. So that pushes us to our next slide. Enoxaparin. Yeah, enoxaparin. There are different low molecular weight heparins. They're actually around 5, but we are looking at FDA approved indications for low molecular weight heparins now. We are seeing enoxaparin. We are seeing another low molecular weight heparin, darutaparin, tinzaparin, and here and this side of the left indication. So we are seeing that FDA approved indications of low molecular weight heparins. The first one in prophylaxis of abdominal surgery, it's enoxaparin and darutaparin. In prophylaxis of total hip replacement, enoxaparin and darutaparin. Then prophylaxis of total knee replacement, enoxaparin. Then deep vein thrombosis and pulmonary inpatient, enoxaparin. Then deep vein thrombosis outpatient, enoxaparin alone. Then arterial coronary syndrome, enoxaparin. Then medically ill patients, enoxaparin still. So I think you can get the reason why we chose the discussion to be mainly on enoxaparin and not any other low molecular weight heparin. Enoxaparin is approved in almost all indications of low molecular weight heparin. So it's the reason we are here tonight to discuss more of enoxaparin other than the other low molecular weight heparins. Next slide. So the next slide is tricky, brings us to brands of enoxaparin in Uganda. We have the Clexane, the original brand. We have Lomo, we have the Parin E, we have Noxa, and we have the newest on market, which is the Enoxaparin, and many more. However, our discussion today will deal, because of the fusions we're going to see in the next slide, we'll deal more in the originator brand, Clexane, and the newest brand, Enoxaparin. Next slide. From my observation as a pharmaceutical representative and marketeer, I realized I made a few observations and realized a few challenges. One is that despite the most trusted and stocked brand of the originator brand, yeah, then here we now coming to the newest brand, which is Enoxaparin, in compared to the originator brand. So Enoxaparin is manufactured by one of the oldest laboratories in Tunisia, Unit, which has over 30 years of expertise in sterile injectable medicines production. Heparin, and of the 5 currently marketed low molecular weight heparins, assured of the same potency and efficacy like that of the originator. And one unique thing about Enoxaparin is that it's by 30% cheaper than the originator, as we are going to see the facts in the next following slides. Next slide, please. So what I realized more, this was published in one of the journals, Journal of Bioequivalence and Bioavailability, comparing our newest brand on as we have seen in the slide, and the product. The originator product is Clexane. The non-clinical and clinical studies, as we're going to see in the next slides. Please, next slide. So the first study was an in vitro study to comparing the anticoagulant activity of Enoxaparin and originator product. It was a study that was carried out in the hematology laboratory of Tenon Hospital, Paris. And just as you can see, Enoxaparin concentration up, down, and up is the anti-factor 10A. So this was the red standing for Enoxaparin, for Enoxaparin, and the green standing for the originator brand. So it was a similarity study that was taken, and just as you can see, at different concentrations, the anti-factor 10A remained at the same levels between in Enoxaparin, just as like that of the originator brand, which is Clexane in this case. So with this, Enoxaparin has the similar potency as that of the originator. Next slide. So from that slide, there were no statistical differences. As we have seen, there are no statistical differences between Enoxaparin and original brand. So Enoxaparin has a similar potency as that of the originator. So Enoxaparin is the newest brand that we have by Unimed Laboratories. As we going to see still in the next study, release. The next study was still comparing that factor 10A activity of Enoxaparin and that of the originator product. This was carried out in a total of 50 patients with anti-coronary syndrome. And just as you can see, still after 4 hours, the anti-factor 10A was monitored in both the originator and the enoxaparin, and as you see, the levels were still the same. So in this case, there were no still significant statistical differences between enoxaparin and originator groups with regard to demographic characteristics. Likewise, there was no significant difference with regard to death, and at 30 days after initial admission between two groups, and no significant hemorrhagic complications in both groups during the follow-up. So enoxaparin is as effective, as well tolerated as the originator brand. So as we can see, next slide, please. The third to the next slide. So this last study that I'm to share, still enoxaparin is a post-marketing clinical study that was carried out in about 238 patients, and in all those patients, 100% of the patients tolerated well the treatment, both in the originator brand and in the new brand, which is enoxaparin. So in this, enoxaparin is similar to the originator brand in terms of efficacy and tolerance. So still in here, there were no significant differences between enoxaparin and originator groups with regard to the demographic characteristics. No significant difference to death, and after 30 days after initial admission between two groups, and no significant hemorrhagic complications in both groups during follow-up. So here we realize that enoxaparin is similar to the originator in terms of efficacy and tolerance. So next slide. Next slide has been explaining what was in the graph. There was no significant differences between enoxaparin and the originator groups with regard. Then indication is an posology. So the indication as posology: one, prophylaxis of defined thrombosis in surgery in the event of a moderated risk surgery, and when patients do not present a high risk of thromboembolism. Effective prevention is by daily injection of a dose of 4,000 international units. The treatment regimen includes 2 hours before surgery. Then for cases of high thrombogenic risk, the treatment regimen includes an initial injection of 4,000 international units and factoring performed 12 hours before the procedure, and an injection of 2,000 international units and factor 10 2 hours before the injection. So that's with the prophylaxis in venous thromboembolism. Next slide. So that's in venous thromboembolism in surgery. Then we go down to other indications, which is
Elizabeth, the slide.
Is Elizabeth on? but we can still go ahead. So with the duration, we have talked of the dosage in deep vein thrombus. Is Elizabeth on? So the duration of treatment in prophylaxis of venous thromboembolism, the duration treatment with low molecular weight heparins with the usual techniques of elastic compression of the lower limbs must be maintained, and active treatment must be less than 10 days out of a particular risk of venous thromboembolism. The benefit of prophylaxis in hip orthopedic surgery by Enoxaparin injection at a dose of 4,000 international units and factor 10A per day for 4 to 5 weeks after surgery was established. If the venous thromboembolic risk persists beyond the recommended treatment period, it is necessary to consider the further prophylaxis, including oral anticoagulants. However, the clinical benefit of a long-term treatment with low molecular weight heparin or anti-vitamin K is not evaluated at present. So another indication is in prophylaxis treatment in medical settings. Here we are talking of patients who are in ICU for long, patients who are on orthopedic wards, non-ambulant, they are there for long. So here the prophylaxis is a dosage of 4,000 international units, subcutaneous daily injection. The benefit of the treatment was established for a treatment period of between 6 and 14 days. No data currently available regarding the efficacy and safety of extended prophylaxis beyond 24 days. If thromboembolic risk factors persist, it is necessary to consider an extended prophylaxis, including anticoagulants. Then another indication is the curative treatment of deep vein thrombosis with or without pulmonary embolism, without clinical signs of gravity. Here, the frequency of administration is 2 injections per day, 12 hours apart. The dose administration, the dose per injection is 100 anti-factor A international units per kilogram. Yes, I'm summarizing. The dosage of molecular weight has not been evaluated by body weight in patients weighing 100 kilograms, weighing over 100 kilograms, or below 40 kilograms. So low molecular weight heparins may appear less effective for patients weighing greater than 100 kilograms, or an increased bleeding risk of patients weighing less than 40 kilograms. So in this case, specific clinical monitoring is required. Then deep vein treatment duration, the treatment with low molecular weight heparin should be promptly related by all at once, except against indication. The duration of treatment with low molecular weight heparin should not exceed 10 days. Other indications for low molecular weight heparins are low curative treatment of unstable angina and treatment of acute myocardial infarction and many more. Because of time, thank you for listening. Back to you, Dr. Mukembo.
Thank you very much, Mr. Nsadhu Emmanuel, for such a good, lengthy presentation that you have given us tonight. It's indeed very, very, very enriching. And from the audience, we've had quite a very good elaboration on how thromboembolic events occur. We've seen some examples of the thromboembolic events, The presenter clearly indicated the cascade of events that follow to the time when you end up with the thrombo-embolic event. And he went down to break down some of the